Thanks, Anton. Don't come to Toronto now. Winter started. It snowed just before I left. Yikes, we hate it. So thank you, Anton and Laura. And I've been asked today to talk about some of the newer agents and the newer approaches. And you can't do good work in HIV unless you work with all of the pharma companies, because they help you and you help them. So as Anton alluded to, one pill once a day, we had it solved. So why on earth do we have to think about having new agents and new approaches? Well, one size does not fit all. Secondly of all, transmitted resistance, although low, still does occur. Adherence continues to be a problem, particularly for some populations. We're still having both long-term and short-term adverse events to different drugs, both in terms of our prevention and management strategies. And along with us, the HIV population is aging, and consequently, with the comorbidities, there becomes an emergence of drug interactions. But bottom line, cost, convenience, and having a choice. Those are the reasons for new drugs. So I'm going to try and walk you through, and I don't want to give all of the data because we've all seen it lots of times, but really sort of talk about how are some of these new agents going to help us deal with some of the problems that we have at hand. So what is new? So the newest drug in the NNRTI family is a drug called doravirine. So why do we need a drug in this field? Well, first of all, it's a single tablet, and it's a little one, which is sometimes important for people. And it can either come standalone or it will be co-formulated with tenofovir and 3TC. So there's a gasp already. What's it doing with tenofovir instead of TAF? But if we'll recall from the studies from Andrew Hill and many of his colleagues, that if you are not taking tenofovir with the protease inhibitors, usually it does not have the renal issues that we may have. So we've got a drug that will be active against HIV and hepatitis B, okay, which is important for many parts of the world. So what are the advantages over the old NNRTIs is it's got less CNS side effects to efavirenz, but was found to be non-inferior in the Drive Ahead study. Its efficacy was also non-inferior to darunavir in the Drive Forward study, and it was able to maintain virologic suppression in the Drive Shift program. So those are all the major clinical trials of this drug. The other advantages compared to efavirenz, it has fewer drug-drug interactions, and there may be some activity of this agent if there is low-grade resistance to some of the first-line agents in this class. So what are the problems? So we're in an era where we're worried about what drugs we give in pregnancy, and we know absolutely nothing about the safety of this drug in pregnancy. And we have seen some emergence of resistance with failure. So the only study that I will highlight then is this Drive Ahead study, which was done in a naive population. It was comparing, this thing is weird, okay. So it was comparing doravirine with 3TC and tenofovir to ATRIPLA. You can see here that there was no treatment difference, but I think we also will look at those numbers, right? Although it is a comparative study, those numbers are not quite what we've come to expect from an integrase inhibitor-based regimen. And in particular, in the population who had the higher viral loads at baseline, these two agents are not performing as well. And as I alluded to, resistance can emerge. So in the patients who failed this arm and in whom they could do resistance testing, there was 1.6% had developed resistance to doravirine as opposed to almost 4% in the efavirenz group. So is a little bit barrier to resistance compared to efavirenz. If we look at the adverse events, so this is really where it does beat that agent in the class, and if we look here particularly at drug-related adverse events, and in particular the CNS, sleepy, dizzy things that we've come to know of ATRIPLA, it is much, much less common. But the big question is, whoops, I'm going backwards. Can I go backwards, Wilco, too? The big question is, do we still have place for an NNRTI in our armamentarium? And I think that's a big question that many of us, back one more, Wilco, many of us, both as clinicians and as politicians and people on guidelines, are really struggling with, is where does this drug fit into the field? And it's unfortunate that we do not have a head-to-head study against an integrase inhibitor to look at how well it performs. But I think a big question for a lot of us is this weight gain problem. And if it's real, and if it is related to the integrase inhibitors, and if this drug doesn't have it, and maybe we're going to find out at the EACTS conference this week, I believe there's a paper about it, it may have a role. So the other major drug that's become available recently, it's called Simtuza in my country. I'm not quite sure what it's called in your country, but this is the first protease inhibitor that's available as a single tablet regimen. So it's darunavir now co-formulated with cobicistat and the TAF form of tenofovir together with emtricitabine. So again, first, PI as a single tablet has a very, very high barrier to resistance. So certainly a lot of people want to use that in a population in whom adherence may be an issue. And it was able to show good viral suppression both in antiretroviral naive patients and in those who were experienced who went on a switch study, and those were called AMBER and EMBER, the two trials. The fact is, it is co-formulated with TAF because, again, we worry about tenofovir together with a protease inhibitor, so the TAF formulation is there, making this safe for kidneys and bones. Problems? Well, it's still a PI, so there are going to be some tolerability problems. It's got cobicistat, so we're still going to have issues with drug interactions. And I don't know about your country, but in my country, it's the most expensive one you can buy right now. And this is just some data from the AMBER and the EMERALD studies looking at virologic response, which were not impacted by either baseline viral load or baseline T count, which we have come to learn of the protease inhibitors over the years. If we look at emergence of resistance in failures, bottom line, there were a couple of people who developed resistance to the reverse transcriptase component of the combination. No one developed resistance to the protease inhibitor combination. So a good barrier to resistance, but at a price of a bit of tolerability and money. Okay, so what about overcoming resistance? And in the past, whenever we've had to deal with multi-drug resistant virus, we always want to look for a drug that's in a new class, and our rules have always said, use 2 fully active agents and an agent in a new class if you can. So one of the new class agents is a drug called fostemsavir. This is a prodrug that is metabolized to temsavir, and this is a drug that prevents the HIV virus from attaching and getting into the CD4 cell. And so the study that was used to enable this study, or enable this drug to be licensed, was something called the BRIGHT study. And there were 2 different simultaneous arms of this study. The randomized cohort was designed for people who had something to pack this new drug with. And so the whole idea is that we were looking for success. So we wanted to make sure that they had 1 or 2 more options to make a viable combination. But the company at the same time wanted to be fair to multi-drug resistant patients who didn't have options. So there was a non-randomized cohort that was run simultaneously for people who didn't have any options in those centers, just to give them access to drug. And how this study worked, and the problem is whenever you're introducing a new drug in a multi-drug experienced patient, how do you know if it works? How do you know if it's this drug versus everything that you packed it with? And so how these studies start is they start with a period of monotherapy where the drug is given by itself for a short period of time so that we could look at the rate of virologic suppression, and then the rest of the optimized background therapy gets put in at the next moment to ensure that patient doesn't develop any drug resistance. And as we might expect, this is just the graph showing what patients had been on in the past and what drugs in blue would be active in their combination. And as you can see, in the randomized cohort, most patients had an integrase inhibitor available to them. In the non-randomized cohort, practically nobody had anything available to them. Nonetheless, patients did have a virologic response. This is data now out to 96 weeks, and 60% of people in the randomized cohort were able to suppress, 37% in the non-randomized cohort. So you may see, well, how did anybody in the non-randomized cohort suppress it all? Remember how these people got there. These people have multi-drug resistant virus that either occurred because they did have good adherence and are just a victim of us learning how to treat HIV properly, or they were people who had problems with adherence all along the way, finally got into a trial and decided to take their pills. So it would be one of the two. Anyway, nonetheless, I think for these multi-drug experienced patients, and although most of us do not have very many of them in our practice, thank goodness, hopefully there is an agent that will be available. But I think once this drug does become available, it's pretty well tolerated. It's a really well-tolerated drug in the patients in our clinic, and of course we all start using things in different places once drugs become available, and maybe this is a drug that will move up the treatment paradigm as we learn more about it. The other drug that's available for multi-drug resistant patients is actually a humanized multi-clonal antibody. And this is an antibody that targets CR4, and it has activity against both R4 and R5 trophic virus. There was a phase 1, 2, 3 stage of the protocol that included 40 individuals, and again, about half of them were able to suppress viral load with about a 60 gain in CD4 count. They then also had an expanded access part of the program in which patients may have access to it when they did not have any other options. And again, you can see that about half of the population were able to respond. So again, the FDA has made this treatment available for patients with multi-drug resistant virus. Of course, the downfall is it's intravenous. The other new agent that is now in clinical trials is a drug called islatravir. This is a drug from Merck, and of course most of us have heard about it as 8591 for a very long period of time, and now it has a name. So this drug now, no, it's not a spelling mistake, it's an NRTTI. And the reason for this is that it reacts at reverse transcriptase at two different stages. One, like the traditional reverse transcriptase inhibitors, by inhibiting nucleotide binding, but it has a second step in which it prevents nucleotide incorporation at the stage of translocation. So it's whamming R2 at two different simultaneous sites. And it's thought that this multiple mechanisms is going to give rise to a bigger barrier to resistance. So we've been able to see the early studies of this compound that were presented at the IS conference this past summer. The original study is what we call phase 2, so it's a dose finding schedule where it was looking at different doses of this islatravir together with doravirine and 3TC that we talked about earlier. And I think you can see on the left-hand side of this graph that we did have very good virologic response with no clear dose difference. And you can see that the number of individuals who had RNA greater than 50 copies at the 24-week was less than 10% in each group. The drug appeared to be very well tolerated with very few serious events and no deaths, serious adverse events, or discontinues related to adverse events, particularly related to the drug. So that's something that we're looking forward to hear about. You're going to hear a little bit more about that drug and different delivery systems as well. So I'm just going to change in the last few minutes to talk about new strategies as opposed to new drugs. And the new strategy that I've raised is two-drug therapy. Well, two. Why two? Why might we think about two when for the last decade it's been driven into all of our brains that we need 3 drugs to maximally suppress viral replication? Well, if 2 will do it, presumably there would be less toxicity. If 2 can do it, potentially there are less drug interactions. You've got more drugs left in case you have to use them down the line. Obviously, it's going to cut the costs if you have fewer drugs. And I think that old paradigm that the barrier to resistance was the number of drugs is perhaps not correct. And it's really the barrier to resistance. How many mutations is necessary to become resistant rather than the absolute number of drugs? So we tried. We've been trying to do this since, well, I forget what that study was called. We looked at Kaletra and efavirenz years ago. Failed, miserable. Why? Nobody could tolerate it. So we tried and tried and tried for many years, but finally now we have found some success, both in switch and in naive patients. And we also now have some convenient 2-pill combinations, so we're back to 1 pill once a day, which is what people want. And I know that you've all heard about the Gemini study. The Gemini study was an international trial in antiretroviral naive patients who were randomized to either dolutegravir, 3-TC, and Truvada, or dolutegravir and 3-TC alone. And we don't need to be statisticians to show that these 2 curves are absolutely superimposable, with 90% of people responding out to 96 weeks, demonstrating non-inferiority of the 2 drugs relative through 3. We've also seen this in various subpopulations, and it appeared to perform well in individuals with high viral loads. The only potential hiccup is it did not seem to perform as well in individuals with low CD4 counts at entry. But when we further look into the reasons for those patients leaving the study, most of them were for administrative reasons and not because of virologic failure. The other 2-drug regimen that we've seen has now been a switch study. This is called SWORD, and so again, it was patients who were suppressed on previous therapy, who had not had resistance in the past, were switched to the combination of dolutegravir and rilpivirine, and again, demonstration that the 2-drug regimen was non-inferior to the 3-drug regimen. And then the last study that we heard about at IAS this year was, again, patients suppressed on previous therapy, no previous failures, switched to dolutegravir and 3-TC, and again, non-inferior to the 3-drug combination. There's the slide there. And no drug resistance documented in any failures. So there we are. We have 3 great studies. Is the field and are the guidelines ready to embrace these strategies? So bring yourself back 10 years. 10 years ago, if I had shown you treatment X with a 90% response rate that persisted for 96 weeks with no resistance and failure and very few adverse events, would you have given that to every patient? Yes. We're hesitating because there's 2 drugs, and that's not what we're taught, and that's not what we feel, and it's not what we've done. We'll get there. But I think it's all going to take us a little while to be comfortable with this. So don't start with your hardest patient. Start with the easy one. Start with someone who's suppressed, who takes all of their pills, feel good about the 2-drug combination, and then move on. So the last comment that I'm going to make is some of the newer agents that we have available are through new drug delivery system. And in particular, I'm going to be talking about the injectables. And the injectables have been studied. The injectable integrase inhibitor that's called cabotegravir, that was studied in combination with an injectable rilpivirine, both agents given by intramuscular injection. These 2 studies again were presented at the IAS conference this summer. One of the studies was in antiretroviral naive patients, the other in suppressed patients. The caveats of the study is in order to be certain the drugs were safe, they were given initially with an oral run-in and then converted to the intramuscular injection. And both studies showed non-inferiority. There was then some data analysis by various subgroups and did not see that one group of individuals was performing any better than the other. The patients, although complaining of some reactions at the beginning of the injections as time went on, seemed to be less concerned about them. So we may ask the question, why? Did they learn to put up with it? Did the nurses learn how to do it right, or what? Remember that these patients did enter into the trial with the hope of getting an injectable, so it's people who are already prepared and ready to do so. No specific adverse events had arisen that were specifically related to the drug that caused people to leave the study. There were, however, so this is, again, did you like this? And I think, again, as clinicians, sometimes we really can't judge our audience. And I think many of us would think, why would you want to come in and have a needle every couple of months if you could just swallow a pill every day? But surprisingly, many patients do prefer that. And often the reason that is stated is taking a pill every day reminds me about my HIV. And if I can forget about it for a while, I'm much happier. And so this was just some of the satisfaction studies that were done as a course of the trials, and people really did seem to be happy with it. Again, remember your audience, they are people who wanted to have an injection. But we all need to think about if we're going to move these into our office, and this is going to happen soon. It's thought that these things are going to be available in the US at the end of this year. In Canada, it'll be 2 years, but it varies. How are you going to schedule these people? Okay, it's really going to be important that we keep track of these people to come in on a regular schedule. And what happens if they don't? Keeping needles and injections and bottles in your clinic is a bigger deal than keeping pills. Where are you going to keep all this stuff, and who's going to keep it all? Who's going to give this injection? And if you're a small clinic, if that nurse is sick, who's going to do it if she's away? We have to think about all these things. And then bridging. What if somebody's going to go on vacation for a couple of months and don't want to take needles with them? Are we going to have some oral bridges in between? What do we do if they don't show? We track them down, find them in the street, because we don't want that long PK tail when the drug concentrations disappear. And I think near and dear in all of our heads right now, and particularly these little hiccups that have come with the integrase inhibitors, what if a woman gets pregnant on this drug? Is it going to be safe? And we need to remember that they can still find this drug in people even out to a year after the fact. So even if they want to plan a pregnancy, how long do they have to go off the drug before they can get pregnant? And then what happens if you get tuberculosis? Okay, you got rilpivirine in there. Is that going to do something to your TB treatment? And so you need to be aware that drug interactions can change while people are on these drugs. And clearly, they're not going to be as cheap as a pill, and therefore many plans are not going to pick them up. So I'm going to stop there, and I think despite the huge success we've had in antiretroviral therapy, we still need new treatments and new strategy to be developed and to be tested. I think these newer drugs can come over some of the deficiencies of our prior regimens, mainly with respect to tolerability and resistance, and I think these newer delivery systems offer our patients some choice. I thank you.